So are you getting my screen now?
Yeah.
Yes.
Yeah. Okay, and this is a very common scenario in our daily practice when you are dealing with the STEMI pathway, and a lot of patients are coming. Some patients are, most of the patients are exactly in time with collaborative efforts of the whole team. But some patients we are facing, which are in between, they are even the late presenters. And for these late presenters, we have no definite cut guidelines from which side we will proceed. So this is I have put two cases in my presentation. It's just a short presentation, but it is very informative for you. And at the end of the presentation, I want professor and other colleagues to give their input, so we can start some proposal for future research for this type of presentation, from this type of cases. So this is the case-based acute coronary syndrome STEMI with late presentation, what to do. I'm Dr. Mohammad Waqas Mazhar, fellow DCB Academy. Moving forward, my basic hypotheses are ST elevation MI with late presentation more than 48 hours, what to do. Do myocardial viability testing is mandatory before to proceed further for revascularization. Post-MI severe LV systolic dysfunction and LV thrombus formation, do minimal revascularization PCI with help to improve LV function. DCB as a tool for minimal invasive strategy for revascularization high-risk lesions despite the myocardial viability testing. So moving forward, this is my first case. She is a 40 years old female with family history of premature coronary artery disease with no any other comorbidities. She presented with acute shortness of breath and chest pain for 2 days. She was having shortness of breath and chest pain 2 days at home. And she presented late in ER department at a non-PCI capable hospital with stable hemodynamics. Immediately, she was ventilated and put on mechanical ventilation because of falling SpO2. ECG detected its ST elevation MI with Qs in V1 to V6. And at that time, echo was done and LV ejection fraction was 25% with anti-wall hypokinesia and LV thrombus formation. After initial resuscitation, she was airlifted to PCI capable hospital in our hospital within next 24 hours. Later, she was having fever. She developed pneumonia, hospital-acquired pneumonia with sepsis, and put on IV antibiotics according to culture and sensitivity report. Later on, once she became stable, she recovered and weaned off after 5 days. This was her transthoracic echocardiogram, which we have done in our CCU admission. Now, what should be the strategy at this case? Because this, you see that there is a clear anti-wall hypokinesia with LV thrombus formation. So either to move with the as a part of invasive strategy to move further, or do we need to wait for resolution of LV thrombus and later on go for myocardial viability testing and then took the patient to cath lab? So what is your strategy in your institution?
Please, guys, speak. Jazim, what will you do?
Yes. So if there is a later presentation in my institution, it depends. Like there is any signs of viability, whether on an ECG or chest pain or something like that, it's a different story. If we don't have signs of viability and echo, we have a akinesia. Here we do MRI or myocardial scintigraphy. Depends on availability, and then based on that, we take the patient to cath lab. Diagnostic angiogram before the viability study to know the anatomy, and based on this, the MRI, we decide whether we.
There is one more thing. Do viability testing we can do immediately within the hospital admission, or we have to wait for a certain period of time and then go for correct assessment of viability testing?
You know, like before there is this, how do you say it, hypothesis of hibernation, myocardial hibernation. Some will delay the viability afterwards. Our practice is simple. We do angiogram, diagnostic. We do the viability, and based on that, we decide the approach. Because if we have access to MRI, it's not easy, but it's kind of give us a lot of information because he will see whether it's edema or it's fibrosis or it's thinned out. He will explain to us whether it's better to recontrol it in 6 weeks or 2 months, or we can rely on the study itself. So mostly what we do is, I didn't face any problem with that approach. Usually he will tell us it's viable, not viable, or I had 2 cases where he told us it's better to recontrol it and if I'm not mistaken, 6 weeks to 8 weeks.
Oh, I see. Can we move forward?
Yeah, please go ahead.
Yeah. So this is the ACS STEMI guideline with late presentation. This is from EAPCI document. A routine primary PCI strategy should be considered in STEMI patients presenting late 12 to 48 hours after symptom of onset. So according to ACC guidelines, ACC 2025 update, stress rapid reperfusion and caution against delays for testing. So rapid reperfusion is critical, and further diagnostic testing should not delay the cardiac catheterization. There is no ACC recommendation to perform viability testing before PCI in late STEMI. The emphasis remains on prompt reperfusion, whether within or beyond standard time windows if ongoing ischemia or high risk is present. There is another 2025 ACC updates guideline for the acute coronary syndrome. They said clearly that no dedicated trials have been done that examine the benefit of primary PCI in patients with STEMI presenting late more than 24 hours after symptom onset who have clinical evidence of ongoing ischemia, acute severe heart failure, or life-threatening arrhythmias. There are few observation studies and small trials suggest that PCI in patients with STEMI with delayed presentation is reasonable and associated with improved outcomes. Now we proceeded with coronary angiograph in this patient. You see the RC is a non-dominant vessel and there's a long left main with mild distal tapering. Circumflex is a dominant vessel and there is a total occlusion of the LED.
Baka, sorry, I don't remember how many hours is this from symptom onset?
Yeah, Prof. Actually, this patient was sent after 3 days to our hospital. And in our hospital, 3 days, 72 hours.
Okay.
And after 72 hours, she was having pneumonia, hospital-acquired pneumonia. When we received here, she was having high blood cell count, white blood cell count, around 30,000. And there were pneumonic patch on the left lung. Then we treated, we wait for her to resolution of pneumonia. Then she was weaned off. And on 8th day, we took her to cath lab.
Do you systematically do a femoral or that's particularly here?
Yeah, you are right. Actually, she was having weak pulses on both sides. So we decided to go with the femoral rather than going from the right radial, because left radial, because she's an obese lady, we tried to go from the left side. We just took femoral because if anything goes wrong, we can put intra-aortic balloon pump or something inside from the femoral side.
Okay, let's go ahead.
Yeah.
Do you have a cranial view? So the topic here is to understand if there is a collateral flow. There is some initial collateral flow, but you don't see. You need to see from a cranial view.
Yeah, right now I haven't cranial view here.
Okay, let's go ahead.
Thank you. Do minimal revascularization study will help improve LV function. PCI is not recommended for an occluded infarct-related RP if the patient is asymptomatic and has a completed infarct. MACE outcome, according to occluded artery trial, which was very far behind, which was a history now, were similar in those with occluded infarct artery versus those who underwent PCI in 3 to 28 days after an MI. Results were no different at 7 years follow-up. Similar findings were noted in the copy which enrolled patients with an occluded artery and Q waves on the ECG presenting 2 to 15 days after symptom onset. So we decided to proceed with minimal revascularization with the help of intracoronary imaging. We did the IVUS initially after wiring, and there is a clear
first of all, you wired easily.
Yeah, we wired easily. We wired easily.
And what did you see after wiring?
After wiring, we just want to do intracoronary imaging first. We proceeded with intracoronary imaging first. And we want to see.
What did you see? What did you see after wiring? What did you see?
Yeah.
Did you see the vessel getting opened or not?
Yeah, no, vessel was not open at this stage. We were not sure. But the behavior of the wire was like it is in the true lumen. Then before proceeding with any other step, we did intracoronary imaging before after wiring.
Okay.
Do you inject after wiring? I mean, like
no. We didn't inject. We just did the wire. Wire was according to behavior of the wire. It was in the true lumen. Then we put the intracoronary imaging catheter, IVUS catheter inside, and we want to see that because we want to check it out because she's a young female. Our first impression was maybe it was a SCAD, and SCAD is ending up with the total occlusion of the LAD because other vessels are almost normal. So first impression, we were looking for SCAD in this case. According to imaging, we use, it has a fibrolipidic lesion. It's a plaque, which is stenotic. There is some dissection here, small dissection, but we were not able to appreciate it's a spontaneous coronary dissection, which is bending all around towards the artery. So we did ballooning, and after ballooning, we did cutting balloon. And after cutting balloon, we proceeded with DCB in this case.
Yeah, but we want to see what you found after each step. If you describe this, we want to see how is the motility, how is the flow, how is the vessel. You didn't put all of this.
No, I just put small short images. Actually,
yeah,
I didn't
but it's important for us to understand.
Yeah, I will send you all the clips. No issue. I will send.
No, but this is a suggestion I'm giving you. So when you present this type of cases, you have to be, very precise, and all of the steps are important to decide, take the final decision of what to do. Okay, let's go ahead.
After DCB, this was our final angiogram, and we did later on echo after 2 days of DCB. And patient was comfortable. She was upright, and almost after 1 week, we started the patient.
Yeah, I don't see clearly the image. It's a bad quality. It's just 3 frames. 1, 2, 3. So you cannot tell about the flow distally. If there was distal embolization, if there was diffuse disease. You can tell from these 3 frames that there is distal embolization and the vessel is occluded distally, or not?
Actually, vessel, you are right. It's a 3-frame angiogram. And there's some clot is also here in the mid LAD as well. And distally, it looks to be a somewhat spontaneous coronary.
Do you have other images? Do you have other angiographies? Probably you took 2 or 3 shots in the end, no?
Yeah. If you give me time, I have images in my laptop.
Please. Yeah, I want to see them. It's important.
Yeah.
Quick question, Prof. If you had the choice here, would you choose OCT instead of IVUS to know if it's a red or white thrombus or something like that?
I think it's not important, what type of thrombus. Probably it's a red thrombus. It's after 5 or 6 days. So no, I don't think that's, usually I prefer OCT, but in this case, I think that it's a good idea to do imaging and to merge the information with angiography, but I would not prefer OCT in this specific case. I don't know.
Are you getting this
Anybody has a
image
different
now?
thought? Now you have to, I think, to stop sharing and share again.
Okay, yeah.
Okay, you have to share again.
Yeah, just a minute. Just a minute, I'm just sharing.
And Prof, quick question for late presentation, STEMI, assuming it's viable, you pass the wire, you inject it, there is no flow. We know it's. Do you aspiration or not here? Your let's say your approach.
No, I didn't do the aspiration in this case.
Yeah, if you have a lot of material, I think you can consider it. It's not risky, and you can go on. If you just dilate, sometimes you have distal embolization, and yeah, so I would consider that.
This is the
But
RA cranial
now,
view.
if you have a 7, 6, so this patient, it seems that the collateral flow for the LED was initial. So you can expect a non-viable anterior wall. So the first thing to do in this case is to have information about viability. So you can have an echo, you can have an echo stress, you can have an MRI, you can have a PET or something. Because you always have to keep in mind that if you try to reopen this vessel, these are the vessels that are associated with complications. Okay.
Yeah.
So if you have a rupture of the anterior wall or a papillar muscle rupture with a severe mitral regurgitation, you have in these cases. Okay, so if you try to reopen the vessel, you have to be sure that you are saving at least part of the anterior wall, because if it's all dead, it's not worth and it's risky.
Okay. So this
Okay,
is the
so
RA cranial view.
here it seems a pretty decent result. There is some competitive flow distally. I don't know if it's a bridging or it's competitive flow because the picture is very small, but I think it's a good result, this one.
Yeah. So we stopped at this stage and then we put on triple regime for this patient, and she will be following in our OPD after a couple of weeks.
What is triple regime?
Triple regime, in this case, we studied that we started with aspirin, Plavix, and also with apixaban, in this case for LV thrombus. And we have a plan to give it for next 2 weeks. After 2 weeks, we will stop aspirin and we will continue with Plavix and apixaban for next 3 months. And later on, we will reassess again, and
Yeah,
we will, yeah. And
nice.
then after the resolution, then we'll go with a single antiplatelet.
Yeah, I agree. Good approach.
Thank you. Now, I have another second case. In this case, we did a hybrid revascularization DCB death strategy for diffuse lesion. He is also a late presenter. He's a 50-year-old gentleman with no comorbidities. He was admitted with acute NTS STEMI, following chest pain for 3 days at home. ECG QS pattern in V1, V6, and LV ejection same. He was having anterior wall hypokinesia with EF 25% and LV thrombus as well. But right now, I haven't his echo images saved in my laptop. But we proceeded with this case with the same strategy. This was his angiogram. You see, this RC is the dominant vessel, and there is very faint apical filling of the LAD, and LAD is totally occluded. When patient came here, he was almost asymptomatic. There was no symptoms, and only his LV ejection fraction was low and LV thrombus on echo. In this case, we started deciding to proceed with PCI without viability. In this case, we found difficulty in crossing the wire. Initially we took BMW, later Sion Blue. Sion Blue was not going into the true lumen. Then we were successful with Fielder XTA. And with Fielder XTA, I was not sure that my wire is in the true lumen or is in the false lumen. We did intracoronary imaging in this case as well. So after confirming that my wire is in the true lumen, I started ballooning the vessel, and with smaller balloon and then larger balloon, and there is some flow in the artery. It's a diffuse lesion, two lesions, sequential lesions. Proximal one is very stenotic, and distally there is a plaque here. But there was no calcium, very or little specks of calcium on IVS imaging. It's a fibrotic plaque. We proceeded with, after vessel preparation, we proceeded with DCB in the mid-distal LAD and one stent, small stent in the proximal LAD. And after that, this was our final angiogram during the first session. We were having a plan to restudy him after 72 hours. So the patient was almost asymptomatic when we took him in the cath lab table. And this was his restudy angiogram after 72 hours. There was a thrombus formation distal to the stent, but the vessel segment which we have done DCB, it was very good. So we put another small stent inside, and this was our final result.
Why did you put the stent there?
Actually, this, yeah, you're right. Actually, this case, second time I was not in the cath lab. My colleague was in the cath lab on that day. And he did, he was not, I asked, he consulted me, he said, you did DCB, there's some thrombus, and he called me on telephone. I was in the ward during that day. And then we have seen, he said that, no, I want to fix it with the stent. I said, no, we can do DC, but he was not agree with my opinion. He said, no, we have to fix it. Otherwise, this is a medical legal issue. We cannot leave him as it is. So due to for preventing from the medical legal issue, he just tried to save himself system.
Okay. Okay.
But that vessel segment which we have done DCB, it was good. There was no issue with the, I was happy with the result. So my take home is that ACS STEMI with late presentation more than 24 to 48 hours should be proceeded with invasive strategy and minimal invasive revascularization if feasible. DCB as a tool for minimal invasive strategy for revascularizing high-risk lesions. If the myocardial viability testing is not available, let the vessel go with the healing phenomena without stent and possible myocardial recovery. Myocardial viability is not mandatory for post-STEMI patient with late presentation having severe LV systolic dysfunction. So what do you think?
So, yeah, thank you.